It's 2 o'clock. Why don't we get this started? Experience tells me that over the next few minutes, quite a few people will start joining the call, which is fine. Just remembered to record, so we'll make this recording available afterward for the folks in our online community who told me they couldn't make it today but are dying to hear you talk. And let's just get right into it. Let me turn this over to the experts who are more interesting than me, but I just wanted to thank the speakers, in particular, Drs. Derek Griffith, Haley Thompson, and Rachel Shelton, for taking time out of your day to do this. We really appreciate it. Thanks to the audience. Couldn't have handpicked you better if we tried. And let me turn it over to Dr. Ellie Daniels, my colleague, my favorite colleague, of course. She is our Senior Scientific Director of Cancer Prevention and Control Research, and she's going to get us started.
Thanks, Joe, and good afternoon, everybody. I'm really delighted to introduce our panel of speakers for the research discussion, Medical Mistrust and Health Equity. All of them have the distinction of receiving ACS funding for their health equity research. As you know, health equity is a priority area in the clinical and cancer control program, which I direct. These folks were some of the first investigators I interacted with when I joined ACS 8 years ago. I remember our telephone conversations to discuss their grant applications and their reviewer critiques. I especially remember their excitement with hearing the good news, your grant's been funded. It's been heartwarming to see their research careers flourish in their advancement to leadership positions while remaining humble and passionate about health equity. They're stellar examples of why we support early career investigators. Each presenter will speak for 15 minutes. Following the presentation, they'll dialogue amongst themselves, and then we'll open the floor for questions from the audience. Please put your questions in the chat box and Joe will monitor them. Our first presenter is Derek Griffith. He's a professor of medicine, health, and society and the director for the Center for Men's Health Research at Vanderbilt University. The second speaker is Haley Thompson. She's a professor of oncology at Wayne State University School of Medicine, my alma mater, and faculty director of Cancer Health Equity Engagement at Carmano's Cancer Institute. And the third speaker is Rachel Shelton. She's an associate professor in the Department of Social Medical Studies at the Millman School of Public Health at Columbia University and director of the Implementation Science Initiative at Columbia Irvine Institute for Clinical and Translational Research. So let's get started. Dr. Griffith, are you ready?
Well, thank you, Dr. Daniels, for that very kind introduction. Let me see if I can, I'm not sure if you're supposed to be able to see me and the slides at the same time. Let's see this again. Okay, there we go. Sorry. Okay. So let me begin again by saying thank you to American Cancer Society, to Dr. Daniels, who's been my officer for a number of years. I don't want to make her or me sound old, but we've been at this for a minute. I'm very excited to be part of this panel with my colleagues, Drs. Thompson and Shelton, who it's always great to work with people that you actually enjoy working with and admire and so forth. So I'm very excited to be part of this work. So let me just jump into this. My role in this panel is really to sort of set the stage and to just give a foundation of terminology. We actually have a project that is trying to understand these issues as it relates to African American men and medical help seeking, and I'll talk a bit about that as well. So I want to start by just acknowledging, of course, my funding from the American Cancer Society. another grant that we have from the Robert Wood Johnson Foundation, which is about trust in healthcare. And we use the example of African American men across 3 generations to basically understand how we better needed to address or think about these issues of trust and mistrust and distrust as it relates to this population and how their issues may not have been captured in there. And then a current precision medicine grant that we have as well. I also want to acknowledge, given one of the people who is just a critical mentor that we lost almost 2 years ago now, Dr. Bill Jenkins, who I'll talk about some of, not necessarily his work per se, but some of the things that he definitely is responsible for bringing light to, which was the end of the U.S. Public Health Service study of untreated syphilis in the Negro male, or sometimes called the Tuskegee study of untreated syphilis in the Negro male. But he worked on the inside of the U.S. Public Health Service and CDC to really raise awareness of the unethical nature of what was happening within the context of that study, and has really been, really was throughout his life, a stalwart, really sort of training, mentoring, and really being passionate about equity, health equity, as well as just trying to raise the profile of faculty and students who are interested in this area. So I want to make sure I honor and remember him. So I also just want to quickly acknowledge my team here at the Center for Research on Men's Health and just all the work that they do, and just to always say thank you to them for hanging with me throughout all this time and the work that we do together. So let me jump into this idea of trust. Again, some of this is going to seem relatively basic, but it's really important as a foundation for thinking about the work that we do as representatives of institutions and as scholars and as researchers, and how we want to work with and partner with community. And trust, we know, is something that can be difficult to build. It takes a long time to build, but once you break it, or once there's sort of a rip or a tear in a trust and in a relationship, it can take a long time or even forever to repair. And it's really important to understand how that actually works. One of the other sort of beginning principles I want to start with is a lack of trust has always been framed, or historically in the context of research and measurement, has often been framed as something that was problematic, not for the participants, but actually, or it was a characteristic of participants or something that we needed to measure in participants, rather than focusing on the fact that how do we help institutions and providers demonstrate that they're trustworthy? And so if we know that there are historical events that have undergird, and that actually people who are well informed about history and educate and what's happened before, if they actually are knowledgeable about those things, they may actually have negative attitudes towards health and well-being that we need to pay attention to. Oops, sorry. And there's a lot of research on trust in healthcare, again, without getting into the weeds of this, but there's a lot of research to talk about the importance of this area as it relates to health outcomes and healthcare seeking. And so this is just, this one meta-analysis is just one example of that. One of the things I wanted to sort of introduce as I sort of get into this area is that who people trust is a really important issue. And while we would think that people may focus on trusting those who have the expertise, the content expertise, the knowledge, the degrees, work for prestigious institutions, that we should, as people who are seeking care, who are seeking services, who are seeking information, should trust those folks. What we find is that when we've talked to African American men, that sometimes they actually are more likely to trust the people in their community who may not have that background, expertise, and so forth, but have nonetheless, over the courses of their lives and experience, they've shown that they are worthy of their trust, that they are people that have their best interests at heart. They are people that love them and that really, show that they are committed to their health and well-being. And while they may not have the same detailed sort of knowledge and expertise and knowledge and expertise that professionals do, if there's a discrepancy between what they're saying, what they know, and so forth, and what a professional knows in seeking healthcare, often they will be more likely to, and somewhat paradoxically, they may be more likely to trust the loved one and the person in their community that they went to and sought out for information and advice than they would the professional, even though the professional has more actual training in that particular area. And again, it's because the person that they're trusting has already shown that they're actually worthy of that trust. They're worthy of knowing them, and they may not have the same strength and length of relationship with a provider. And if the provider doesn't show that they're taking the time, putting in the energy to actually try to understand the perspective of the person that is sitting in front of them, the patient that is sitting in front of them, the research participant that is sitting in front of them, then they're less and address some of the concerns, issues, and frankly, even misinformation that they may have, that they're less likely to trust that person than they are the person that's shown that they're actually committed to their health and well-being. And so it's important to understand help seeking in that context, and even this concept of trust and mistrust in that way as well. So just very quickly, just basic terms, trust is a belief in a person's
Hey,
competence
Alicia. How are you doing?
to complete a certain task. And
You're gonna talk?
distrust is the idea that you
Oh,
may
okay.
or may not question the motives, the sincerity, the genuineness, and how worthy the object is of trust. What distinguished in the object here, I mean, a provider, an organization, an institution, and so forth. And the distinction here is that mistrust is generally just of a broad sense of skepticism, unease, and concern, and just not being able to sort of bring your full self to a particular experience like seeking healthcare, and that may result from actually being, again, a little bit paradoxically well informed about the fact that there are historical experiences that may actually give you some credence to say, I should at least be a little bit skeptical, or at least go into this particular situation with a little bit of caution, because it is possible. It is possible given the historical fact that these things have happened. And so distrust is distinct from mistrust, in that distrust actually is about the specific experience you've had or that somebody has had with a particular provider, organization, or institution. Mistrust is a more general sense of unease, dis-ease, suspicion, concern, skepticism that you may have just based on, potentially good information, based on just group identity and experience, oral tradition, and other factors, and just vicarious experiences or learning from the experience of others in your community or that you may know. And so while it's important to think about these ideas of trust and mistrust in relation to race and ethnicity, and for the most part, that's where it has been typically studied, is in relation to African Americans and the levels of, as a primary explanation, linking experiences of racism and discrimination and healthcare seeking, that it's not limited to that. And some of the recent work has really tried to expand this work to really recognize that things like class, homophobia, transphobia, and other things may also contribute very substantively to why people are lacking trust in seeking care, in participating in research, in doing things, and that experience and that history is unfortunately, sadly, just as robust and strong as the history that we've seen of racism and discrimination in healthcare that we've seen represented in studies like Tuskegee. And so just very quickly with the Tuskegee study, it's important to kind of think about sort of why is this such an important marker or such an important example of the kinds of things that people have concerns about, and why does this actually matter? Well, it matters because historically, even if one of the things that Dr. Levis and colleagues did some years ago is looked at whether or not there was a relationship between whether or not people actually knew the facts of the study and their levels of mistrust and distrust. And they found that actually there was not necessarily a relationship between their knowledge of the facts of the study and mistrust in medical care. What was important, though, is they still knew that this was an issue. They knew that this thing had happened. And even if people don't know the details, even if they have misinformation, that they still may be likely to be skeptical and react to it and respond to care, respond to opportunities to participate in research through the lens of being skeptical of this whole institution and of these opportunities to participate in research, simply because they know that something like a Tuskegee happened, something like a study that is in Guatemala, where we actually, part of the U.S. Public Health Service, actually one of the people who led the study at some point in the later parts of the study in the 60s and early 70s before it was halted, a Dr. Cutler, actually was instrumental in also doing this study to understand the natural history of other sexually transmitted infections. And in this case, in Guatemala, they actually facilitated people actually being infected with these sexually transmitted infections so that they could study the biology of how STDs has affected the body and whether or not they could treat them and how they could do that. And so as opposed to Tuskegee, where they actually people were not, which is one of the pieces of misinformation that we often hear, these folks were actually actively infected, and our government and the researchers actually facilitated this and tried to get people infected so that they could study these issues. And so these lapses in people's concerns about what's possible for researchers to do, what's possible for government-funded research to be able to do, is something that's real if you actually know this history. And so it's important to understand this in these issues in this historical context. And that, again, knowing that these things simply happened is not just an issue for African Americans, it's an issue for other folks who just may be well informed about history. And so when you have concerns about what medical care providers are doing or not doing, you're operating within this context that these things have actually happened. You're operating in this context that you're representing an institution that, no, you may not have done those things that are untrustworthy, but you nonetheless are bearing the responsibility of doing research and providing care in an environment where these things are part of the context that you have to then overcome. And it's important to understand how these negative experiences that your patients or your research participants may have experienced personally or may not have experienced personally, how those things affect whether or not they're willing to engage in and participate in your research. And one of the things that's important is sometimes if there's a perception or the reality that there may be competing interests between providing the care, the quality of the product, and making money, that there are a lot of concerns that people may have about whether or not they're going to get the best quality care. So it may not be that they're fearing that they may be infected with something, or that there may be something particularly nefarious. It may just be that they realize that there may be some unintentional but nonetheless important implications of people prioritizing making money over necessarily the quality of the care and research that they're getting. And so those conversations are important to understand, that people bring those concerns to the table when we have these issues as it relates to medical mistrust and distrust of certain institutions. And so it's important to understand that these issues that we learn from this history of racism, discrimination, and other forms of discrimination that we consider. So just to close, we know that there's this quote that lots of things are attributed to Mark Twain, but this is just one of them, that history doesn't repeat itself, but it often rhymes. And so when people know a particular history and they're feeling something or hearing something that sounds like the Tuskegee, it sounds like the Guatemala STD experiments, it sounds like other things that have been done in other contexts that are problematic, they will hear that connection and they will make that connection, and we have to figure out how we're going to overcome that. So thank you.
Thanks so much, Dr. Griffith. This is Joe, and Dr. Thompson, I'm pulling up your slides now. You wanted me to advance them for you, is that right?
Yes, please.
Okay. Can you all see them okay?
Okay. Thank you, Dr. Griffith. That was, there are definitely several points I'd like to kind of revisit when we come to the discussion part of our presentation. But I want to thank the American Cancer Society and Dr. Daniels for including me in today's discussion. I'm really, really excited to present to you all today. And I decided I was going to present on the group-based medical mistrust scale. A look back and a look ahead. This is a scale that I and my colleagues published back in 2004. And so, now is probably as good a time as any to kind of think about the work that's been done in this area with this scale and what might be done in the future. I also am going to try to connect this to the health equity research that we all conduct and think about what are the implications for that work as well. So next slide. Next.
I'm on slide 2, Dr. Griffith's presentation. You want me to go to the next slide after this?
Yes. Wait, so you're
You're on.
Maybe there's a bit of a lag from when I
oh
go.
maybe it's on my part, there might be the lag.
What I'm seeing is Dr. Griffith's presentation, the slide 2 of yours, which kind of summarizes his presentation.
Right. Okay. Oh, I'm sorry, and I'm not seeing it. Got it. Okay. So,
Can anybody else see it?
No, we're just seeing the title slide
Yeah.
of Haley's presentation.
Let me try to stop sharing and then share again. Okay.
Okay.
Sorry about this. Okay. Did that work?
No, we're still on the title slide.
Hmm.
Okay, I apologize for this.
How's the connection on your end? Would you be able to share it from your side?
Yes, I would need a second to pull it up, but maybe in the interest of time, we should go ahead and hold on. Let me see. Okay, I got it. Okay, so can everybody see the next slide?
Not yet.
So I don't know if others can see this, but there's an arrow that says slide 1 of 17, 2 of 17 with arrows to the right and left. I think participants or observers might be able to advance the slides on their own.
Okay.
How strange.
Yes, I can advance on my own.
Yeah,
Okay.
me as well.
Let's do it that way. So we're on the second slide.
Okay.
Okay, cool. Sorry about that. So what is medical mistrust? So I've had a long-standing interest in medical mistrust. And I really wanted to kind of refer back to Derek's presentation, his definition of medical mistrust. A general sense of unease or suspicion that the healthcare entity might not act in the patient's best interest, and it may originate from a distinct historical experience related to identity, personal experiences, or vicarious experiences. And this definition really resonates with me. It resonated with me as I was starting my career and interest in studying medical mistrust. So I want to talk a little bit about what kind of shaped my understanding of mistrust. So can we go to the next slide, everybody? Oh. Is everybody there with my experience?
Yes.
Yes, cool. All right. So I wanted to share a little bit about my background and why, again, that definition really resonates with me. So I was born and raised in Brooklyn, New York, East Flatbush. Right onto the left, you see pictures there of Kings County Hospital Centers, the largest public hospital in New York City. That's my neighborhood in East Flatbush. We lived right in the neighborhood, and my mother worked as a nurse at Kings County Hospital Center. And it's just in terms of the neighborhood, it's a predominantly Black neighborhood. Not only is it predominantly Black, it's predominantly Caribbean. My family are Caribbean immigrants. So this is important because, being near this hospital and having my mother work there really shaped some of my understandings about healthcare. You all might remember gosh, it seems like forever, but only like almost 2 years ago, there was a lot of attention in the news to Governor Ralph Northam of Virginia, his yearbook pictures. right? He's a physician, he's a governor, but these yearbook pictures emerged where he was wearing blackface. And I took that as an opportunity to submit something to our local newspaper, the Detroit Free Press, and wrote an op-ed piece just connecting how racism that kind of is connected to what we saw with Ralph Northam is connected to Black patients' medical mistrust. I'm going to read what I have here on the screen. My mother worked as a registered nurse in the largest public hospital in New York City for most of her career. She would describe how the mostly Black and immigrant patients would first consult with white doctors who assumed that their directives would be followed. And then these patients would debrief afterwards with the nurses of color, like my mom, who looked like them. Nurses they trusted more than the doctors. To be sure, Northam's past antics may be an extreme example of racial insensitivity on a continuum among physicians, but that continuum exists all the same. Black folks' medical mistrust is not cultural. It is rooted in the realities of past and present racism. And I thought I wanted to really share this because it really, that my personal experience and the experiences of my mom's patients and my family members really shaped how I wanted to approach medical mistrust and the way I thought it was important to measure medical mistrust. So we're going to go to the next slide 4. So just in general, measuring mistrust, when we think about assessment, it tends to focus in 2 areas very broadly, right? Interpersonal mistrust, so that's a mistrust of a specific physician or healthcare provider, or actually distrust, right? As Derek just mentioned. And also institutional mistrust, which is a little broader, which can be people's lack of trust or suspicion of physicians or providers in general, or the medical profession in general, or healthcare organizations and hospitals, health insurers. I believe there's at least one measure of health insurer distrust, and pharmaceutical companies as well, right? But all those did not necessarily, the measures that existed at the time when we developed the medical mistrust scale, they didn't really tap into, again, this racial discrimination. They didn't tap into racism or social inequality. So we go to the next slide, 5. Right. Again, it was really important. Again, I knew because of the way that I had grown up and the stories that I've heard, that it was important that a measure captured the intersection of racism and mistrust in the healthcare context. So, and we developed this scale around, like I said, in the early 2000s, around 2001. I was a postdoctoral research fellow in East Harlem at Mount Sinai School of Medicine. And at the time, there really wasn't a scale or a measure that really captured this. The closest measure was the medical mistrust inventory, which captured it in some part, but again, didn't necessarily go in depth in terms of racial group membership or any group membership and how that affected trust. We also, there was the cultural mistrust inventory that could be relevant to this area as well. So that's really what led to the group-based medical mistrust scale. So I'm going to go to slide 6. And the group-based medical mistrust scale, GBMMS, was intended to measure the tendency to distrust medical systems and personnel believed to represent the dominant culture. And it's group-based in that it assesses the tendency to distrust those who don't belong to one's ethnic group or systems that don't represent one's group. And it's based upon a legacy of racism and unfair treatment. Okay, so I'm going to go to the next slide here, to number 7. And I think, some of you may have used the scale and are familiar with the subscales, right? And there are 3 subscales that emerged from the work that we did. The first is the suspicion subscale, which really captures that mistrust, I think, most effectively. In fact, it is the most robust of the subscales, having used it in a lot of different types of studies and people's experiences. If you don't have space for all 12 items, just use the suspicion subscale. Again, it's quite robust. There's also a second subscale looking at group disparities in healthcare, and then the third subscale addresses lack of support from healthcare providers. So I've kind of tracked the use of the scale, and it's been very surprising to me, actually, because I never thought that back in 2004, when we published the scale, that people would still be using it, but they are. So I try to track what, and I know there've been some recent literature reviews looking at mistrust and mistrust measures. And I think one of the more recent ones stopped somewhere around like 2017 or 18. But since 2004, there have been 68 peer-reviewed studies that have actually reported administering the GBMMS. And maybe they're looking at it as a predictor of an outcome, or maybe it's the outcome itself. Sometimes it's a mediator. But what's interesting here is that about half of these studies have been published since 2015. And one of the takeaways from that for me is that, you know, medical mistrust and this kind of group-based or even race-based medical mistrust continues to be viewed as an important issue when it comes to health disparities. I mean, it's still kind of viewed as an area that I don't think we've tackled very well, but yet is still affecting health outcomes and healthcare. Next slide. And what has happened is that, you know, the reference groups have been expanded as well as different correlates and outcomes. So it's been looked, even though it was originally created with different diverse racial and ethnic groups in mind, it's been used across a range of different groups. So certainly we have different racial ethnic groups here, African Americans, Latinx groups, South Asians, Aboriginal peoples, but it's also been used in rural populations, not just white rural individuals, but Black and Latino rural populations, LGBTQ individuals, and also in different specific patient populations like pediatric emergency patients or recently incarcerated adults. And the correlates and outcomes also have some range. So the original study looked at mammography screening and breast cancer screening outcomes. And it certainly has been continued to be included in studies of cancer screening and treatment and survivorship attitudes and behavior, but also it's been used in the HIV research world, looking at ART adherence, HIV management, PrEP use, hypertension management, problem drinking, medication adherence and self-management, genetic risk assessment, certainly patient-provider communication and patient satisfaction with care and just quality of life. But again, what does this tell us? This tells us that, again, mistrust, and again, specifically this group-based mistrust that's connected with unfair treatment is not only viewed as being critical in the disparities we view across different groups, but across a range of different outcomes as well. And and I should mention that, you know, for many of these studies, there are clear associations between medical mistrust and these correlates and outcomes. And what's important to note there is that measurement and the way we measure mistrust really matters. So I'm going to go to the next slide. Because often, when the group-based medical mistrust measure is included along with another measure of trust or mistrust, it often yields different results. So I have examples of two more recent studies that show this from some of actually my colleagues. So in the first one that looked at willingness to discuss clinical trials among men with prostate cancer, among 200 Black and white men, group-based medical mistrust, which was really more race-based because we made it specific to race, but not general trust in medical profession, was associated with lower willingness to discuss clinical trials. So not general trust, but it was specifically that race-based trust. We also, in another study, it was found that among Black cancer patients, not general mistrust of physicians, but again, that more race-based mistrust was directly associated with lower patient ratings of their physicians' patient-centeredness, lower levels of patient confidence in their treatments. And it also affected, this is interesting, it affected physicians' perceptions of the patients. So when a patient had higher group-based or race-based medical mistrust, their doctors perceived them less favorably when it comes to those attributes associated with successful treatment outcomes. So less intelligent or less likely to live a healthy lifestyle. So again, that racial lens through which we're looking at mistrust seems to matter. Next, I'm going to go to the next one. And I just wanted to share here, just in terms of expanding it to yet another area, COVID-19. I'm going to show you just actually one slide and one finding from a study that we've been doing, a survey we've been doing funded by the NCI. It's a supplement to our Cancer Center Support Grant, focusing on COVID-19 cancer and community. We're part of a consortium of a number of cancer centers looking at the impact of COVID-19 and social distancing on cancer care and healthcare in general. And one of the questions we asked, of the many questions we asked, If you were offered a coronavirus, a COVID-19 vaccine today, how likely is it that you would be vaccinated, right? And so, again, I'm going to take you to the next slide, if you move forward. And this is still preliminary. This is from based on over 1,400 Michigan residents age 18 and older. If you were offered a corona vaccine that had been approved today, would you agree to be vaccinated? So you can see to the left, we have, this is all the participants or respondents. About half said yes, definitely or probably yes, but in the blue, we combined people who said definitely or probably no or neutral, neither yes or no. So pretty much half and half. And when we looked at predictors, at least race and group-based medical mistrust, the suspicion subscale, as predictors of that agreement to be vaccinated, we see that African Americans are less likely compared to whites to say yes, they would be vaccinated. In fact, 70% of Black respondents were no or neutral. And then we look at race-based mistrust, the same trend. So with greater mistrust scores, we see a lower likelihood that people would say they would agree to be vaccinated. So again, it continues to be a potentially important factor, but part of this is to understand this in context, right? So let's go to the next slide. Because people's lack of willingness or the lack of agreement to be vaccinated is more than just about vaccine hesitancy, right? Like when we think about with HPV vaccines or the kind of concerns about safety, right? It's informed by at least a couple of things, right? And I know we didn't ask about this or we haven't asked about this, yes, but I'm willing to bet that this lower willingness is informed by the striking racial disparities in COVID-19 mortality and morbidity that we've observed since the beginning of this pandemic, when we've had this really bright light that has been shining upon kind of the racial inequities in health. But it's also informed by the social, political climate, with emphasis on political climate in which these vaccines are emerging, right? They're emerging under kind of national leadership, which a lot of people, particularly a lot of African Americans, do not trust or do not believe they have their best interests in mind. And I think that's really important as we kind of continue our work in medical mistrust, is to understand it in context. And to the right there, I have the social ecological model, which many of you are probably familiar with. But it's not just about, it goes beyond our healthcare experiences, right? It can include our other institutions and what's going on in our communities and even on a legislative level. Those things can influence people's medical mistrust. And I think we can be doing a better job of taking that into consideration in our work. And at the bottom here, I wanted to show a very recent study that I found, I came upon not too long ago, looking at police brutality and mistrust in medical institutions. And it also used the group-based medical mistrust scale. And I'm just sharing the main findings there. Respondents who had negative encounters with the police, even if they perceived these encounters to be necessary, had higher levels of medical mistrust compared to those with no negative police encounters. And police brutality increased mistrust for all racial groups. And it's interesting because
so did we hear from UNC?
Hello? Oh, okay. So
okay, great. Perfect.
So I think somebody needs to is not muted. But the discussion of this actually mentioned that, what do we do? It's like, well, maybe providers need to really focus on systemic change, because clearly it's these other systemic factors that influence their medical mistrust. So just to move forward, I'm coming to the end here. In terms of future directions, I think there's always more that can be done in terms of theory and measurement. I think there is space to, and I know some people have done this a little bit somewhat with this scale, but we certainly, there's more that can be done with the group-based medical mistrust scale. There are other measures to be developed. Maybe we need to think about revising existing measures to reflect current events and evolution, and thinking about race concordant and discordant clinical interactions. Today, I think we have a much more, especially even in the general culture, we understand more about implicit bias, right? People kind of are more familiar with the term and what it means. Maybe that should be more, we can integrate that into our understandings or our assessments of mistrust. Should our measures be more tailored to specific group experiences? One of the advantages of the group-based mistrust scale is that you can change the reference group, but maybe we need to do more than that. Maybe it can be something like the FACT measures, which is the functional assessment for cancer therapy. There's a FACT G, which is general, but then there's a FACT B for breast cancer, a FACT P for prostate cancer. Maybe we should be adding on items or subscales that really delve more deeply into the experiences of specific social groups. There's certainly much more to be done in applied research, longitudinal studies of mistrust and how that unfolds. Certainly, many people have talked about the impact of family and social networks on mistrust and intergenerational effects of mistrust, on mistrust and on healthcare. And certainly, there's a lot of room left for interventions. However, all this research must carefully consider the social ecological context of medical mistrust, because based upon this idea that social inequality drives mistrust. And so I just wanted to say a final couple of things about health equity research. Just research is the formal definition is that it's the generation or creation of new knowledge, and health disparities persist and are intractable. I think new knowledge is desperately needed. But sometimes the knowledge we need isn't really new. It exists, but just hasn't been heard, acknowledged, prioritized, or valued by the majority. One of the reasons why I wanted to share my background with you is because I feel like, when we developed the medical mistrust scale, the group-based medical mistrust scale, drawing upon the literature and existing measures and both quantitative and qualitative work. But my mother could have created that scale. A lot of the things that are captured in scale, I've heard in my home. I've heard from my parents' friends, and even now I still hear those things. So it kind of, I guess, took me, in my postdoc to kind of maybe help to try to bring that to the forefront. And I think it's important because I think that it's important that our work be informed by our lived experiences, and the lived experiences of the communities that we serve through our research. And I just wanted to summarize by talking about this idea of voice. This is a principle that's talked about as part of public health critical race praxis. And it's can be defined as prioritizing the perspectives of marginalized persons or privileging the experiential knowledge of outsiders within. Who are the outsiders within? It's people of color, it's LGBTQ folks, it's people who are differently abled, it's rural folks, it's people who have grown up in poverty. Nobody talks about growing up in poverty. There's so much shame around that, but it's important that we bring in these perspectives, right? And I just, to the strengths of voice, it captures the potential of outsiders within to notice patterns and relations not apparent to persons socially located in the mainstream. It's a very different perspective that I think is needed and I think is really key in terms of achieving health equity and doing the work that we do. That's it. Thank you.
That was lovely, Dr. Thompson. Thank you. Dr. Shelton, do you want to take control by clicking, thanks Dr. Hopper pointing this out, click the take control button at top and then share the PowerPoint slide you'd like to share?
Okay.
Or I can.
Here, let me try one more time. There, do you see my screen?
Yes.
Okay, how about my slides?
I see them.
Are you able to see them advanced?
Yep.
Yep.
Great, perfect, great. Thanks so much, everyone. I'm so thrilled to be here. And thanks to Dr. Daniels and Joe Cotter. And I'm thrilled to be on this panel with Derek and Haley. And I think Derek and Haley have done an excellent job really providing some of the foundational grounding in terms of the definitions of trust and mistrust, and really the operationalization and measurement, which are so critical. So I'm really going to build off of what they've provided and really think about some of the application in the context of my research that I'm going to share. So a lot of my work over the past 12 years or so has really been focused on issues of equity. And I think what's distinct here between disparities and an equity focus is that equity is really justice-oriented. It is really action-oriented. And it really recognizes that there are social and structural determinants that shape the inequities and that reinforce them. So it really calls that out as unfair and unjust. I really came to medical mistrust through some of my dissertation work originally. So I was doing some work really thinking about the broader social context in which health behaviors occur, and was focusing a lot on discrimination and racism and its role in shaping cancer screening. And through some of the qualitative work that I was doing in the community, I kept learning and hearing how closely medical mistrust was linked with discrimination and racism, and the implications that that had for health behaviors, not only cancer screening, but other health behaviors as well. So I want to share a quote from my dissertation work, which is now published. One African-American woman in the sample said, you know, because of what society used to do to us as people, some of the elders are fearful going to doctors. Based on their skin color, we used to actually have doctors who would call us problems as opposed to taking care of our problems for medical research, because they figured our people weren't worth the value. And there are a lot of people who are alive today that won't go see a doctor unless you're there with them. You have to walk them through it because they actually fear that they're going to create something on them. And another woman shared, you know, I have a problem trusting doctors, especially over the history of medicine. They've always used minorities in their experiments, in their procedures, and that goes way back now a stretch. So it's really critical, just as Derek and Haley have highlighted, you know, mistrust is really rooted in specific historical events, whether it's Tuskegee, we could talk about Henrietta Lacks, but honestly, there are numerous historical examples of racism and discrimination in public health and medicine. And I think what really stood out to me in the research that I was doing at the time was it wasn't only historical events. There were also their own personal lived experiences that were present day, you know, in terms of whether they were experiencing unfair treatment or discrimination in the healthcare system or more broadly in society. So I think that's really critical that, again, as Haley was highlighting, medical mistrust is so tied to the social inequalities at multiple levels in our society. I actually did my postdoc work with Haley at Mount Sinai. And so I got to do some work with her on validating the group-based medical mistrust scale among you know, several groups, including incarcerated men and men in New York City. And I was really interested in also thinking about, are there actually interventions? Are there practices or programs that are actually trusted by communities experiencing these inequities? And I became really interested in lay health advisor programs because these are peer-led. They are members of the community who are trained, who are leaders, who are already trusted messengers. And there's already been a lot of evidence over the past 30 years or more of their effectiveness in actually addressing inequities for a number of health issues, including cancer screening. So I really wanted to think about, how can we amplify this work? How can we get this out more widespread into the community to address some of these disparities that we're seeing in breast cancer in particular? So I had the opportunity through Haley and other colleagues at Mount Sinai to be connected with this amazing group of lay health advisors from the National Witness Project. And here we are. This is from 2010 when we first got our first NCI funded study together, and we were launching it at a national meeting. So this program was really developed by African-American women, for African-American women. And again, its explicit focus was really to address a lot of the mistrust, the stigma, the discrimination that women were experiencing in trying to access cancer screening services and really navigate the system. So the program is really provides these educational group sessions in a range of community settings. So it started out very faith-based, but now it's in a variety of community-based settings. And peers are trained to deliver support, resources, education, systems navigation. And half of the women are themselves cancer survivors, and they provide these really powerful testimonials and narratives about their experience of how they identified their cancer, how they navigated the system, how they you know, communicated with providers. It's extremely powerful witnessing this. This program has been highly effective in terms of increasing breast and cervical cancer screening and diagnostic follow-up. It's been identified for many years as one of NCI's evidence-based cancer control programs. And amazingly, it has been nationally disseminated and implemented for over 25 years across the country and impacts thousands of women per year. So when we started partnering together, they said, that's great, but we really want to learn on the ground and really address some of the challenges we're having in sustaining the program. You know, despite being such an exemplar, they were really having a lot of issues with keeping the programs going. So I have to say that is really what brought me to the field of implementation myself as a researcher, to really think about solving this real world challenge of sustainability. For those who don't know, implementation science is an area that's really grown in the past 15 years as a field. And it was really developed to address this really well-documented gap between research, all of the evidence-based programs and practices and interventions that we have that have been tested to be effective, and then practice, what's actually routinely delivered in all of our real-world settings. And the field really tries to identify methods and strategies and frameworks that can really actively promote the adoption, use, and sustainability of these evidence-based interventions and practices, again, in these real-world community and clinical settings. So I'm not going to go into this, but I do want to highlight that the bulk of my work over the past 10 years has actually focused on partnering with Witness to understand how can we sustain programs, especially in settings that are under-resourced or that face so many structural barriers. As you probably know, trust is a huge part of that. So I've put some references here. But today I want to focus on some new information and kind of a new area that we're developing. So we have an American Cancer Society funded grant, and Dr. Daniels is my program officer. And again, the bulk of the study is, again, focusing on sustainability. But our last aim is really thinking about this concept of de-implementation and adaptation. How do programs actually stay evidence-based over time? How do they adapt or not to meet changes in screening guidelines or other scientific evidence? So that's what I want to talk about today. As you probably know, screening guidelines for mammography have changed multiple times over the past 20 to 25 years. We've seen the removal or lack of recommendation now related to clinical breast exam and breast self-exam. We've also seen that the interval at which mammography is recommended and the age of initiation has shifted as well. In general, we've seen a move towards more informed decision-making and more breast self-awareness. It's important to note, though, that guidelines are actually inconsistently nationally across organizations, and research suggests that that's quite confusing for women in terms of which guidelines to follow. So in the field of implementation science, there's been a lot of emphasis on thinking about continued delivery of programs with fidelity. So looking at the extent to which the original program or the guidelines are adhered to. And importantly, there's been a move away from thinking about that so rigidly and really recognizing that, of course, over time, our contexts are dynamic and they change. Our population needs evolve over time. And the scientific evidence, of course, is going to adapt and change over time as well. So now there's recognition that our programs actually should be adapting. It's appropriate that we're making adaptations to our programs over time. So now in the field, not just thinking about implementation of evidence-based programs, but actually thinking about de-implementation or the removal of practices or programs that are no longer supported by evidence, that are costly or are not effective. And at NCI, Wynn Norton and David Chambers have done some great work, but there's not been much empirical work in this area. And I just want to note in the context of this study, what we're talking about then would be adaptation to meet new screening guidelines in terms of, age of initiation, the interval, but also de-implementation of the screening practices like breast self-exam and clinical breast exam that are no longer recommended. So I won't spend a lot of time, but again, this is data just from the last year. This is brand new data that we've been collecting among 14 sites nationally. And we did both surveys and in-depth interviews. So as you can see, we have a great distribution nationally in terms of our sites, in terms of representing the experiences of women. And we have 14 project directors who participated from these sites and 187 lay health advisors and cancer survivors, all of whom identify as African American or Black women. Huge age range from 20 to 80. So what screening guidelines are sites using now 25 years after the program was originally developed? We're finding that a lot of women cite really relying on Witness themselves as determining the screening guidelines, but also 40% mentioned American Cancer Society. Very few rely on U.S. Preventive Services Task Force for their guidelines, and some were unsure. In terms of mammography recommendations, we find that a lot of the women are recommending mammography earlier than is typically recommended, so initiating at age 40, and annually, which is a little bit more often than is typically recommended. And this is more consistent with what the program looked like when it was originally developed. But as you can see, it's a little distinct from a lot of the existing recommendations currently in place. In terms of awareness of the guideline and program changes, we found pretty high awareness, particularly among the project directors, of changes in screening guidelines in recent years, and pretty consistent reports of changes that have actually happened in the curricula in terms of screening guideline changes within the Witness project, as you can see here on the right. We also found really strong attitudes and beliefs about the importance of following evidence-based guidelines. And again, this belief that Witness actually does adapt to the evidence base and itself is an evidence-based program. But when we looked at actually the delivery, what's actually happening on the ground in terms of whether or not women are making the adaptations when they deliver the program, we found that generally most women are not removing a clinical breast exam or breast self-exam as part of the education. We saw a little bit more adaptation related to the interval of screening for mammography and the age. But again, consistently across the board, we're not seeing widespread adaptation on the ground in delivering the program. So we wanted to unpack this and understand a little bit what's going on here. And so there are some validated measures that look at why people might be hesitant to de-implement, but they did not include trust. And we knew that this really might be an issue from some of our pilot work. So we added some items about trust of guidelines. So I'm just going to highlight a few of our findings for you here. So we found that there's really only moderate levels of trust in medical organizations and providers. So about 53 to 57% of project directors and lay health advisors reported trust. A little bit better with the guidelines, trust of the guidelines, with 67% of the lay health advisors reporting this, but distinctly lower among the project directors. We also found only moderate support of this idea that women in the community would actually support making these recommended changes. And again, some moderate support that LHAs and role models who are the cancer survivors themselves were on board with the recommended guideline changes. I thought this was really interesting. So very low support of the idea that the guidelines are a valuable addition to the program, so less than half. And only about 30% of the women thought that the guidelines themselves were compatible with their own personal beliefs about breast and cancer screening. We did see, though, that women continued to believe that there is strong scientific evidence that breast self-exams and clinical breast exams are effective, and that there was strong scientific evidence to inform changes in the guidelines. So we used our qualitative results again to unpack this a little bit and understand a little bit more about what was going on. And this was really, really important. So there were many challenges identified to adapting to these new guidelines. One really important perception that we heard is this idea that African-American women actually are diagnosed at younger ages with more aggressive cancers. So they often felt like the guidelines themselves are not reflective of their own experience. We also heard this idea that, this perception that the guidelines keep changing. They've changed multiple times. They're going to just change back again. And if they actually change the program and adapt and get African-American women on board, and then they change again, they're just going to be left behind. And they're ultimately going to end up distrusting the program. So they were very hesitant for that reason. There was also this belief, again, that the data that informed a lot of the trials and guidelines did not reflect African-American women. And in particular, this idea that a lot of African-American women may not have access to providers, may not trust them, and may not be receiving mammography. So this idea that breast self-exam may be one way to reach women who face so many structural barriers. And I think it's so important to note that, again, many of the survivors in the program actually identified their own cancers through breast self-exam. This was such a foundational part of the program. So asking them to remove it, I think, felt very disempowering for them. We also found out a lot about ways that people are shifting and reframing some of the adaptations within the program. So a lot of the programs were now framing breast self-exam not as a screening tool, but as an education and empowerment tool for African American women to really be invested in self-awareness of changes in their bodies. We also heard how they're using the new guidelines as an educational tool for African American women to advocate for themselves in the context of their own doctor's appointments and communication about how it did not reflect their own experience or the data for African American women. And finally, they noted really thinking about leveraging trust in the National Witness Project as an organizational research to communicate any changes in guidelines. And one project director shared, I'm not sure if they trust the guidelines. I just know they trust the Witness Project. So I think these findings really underscore, again, this foundational, persistent influence on really many domains in implementation science, but specifically here thinking about how we adapt and de-implement in the context of changing scientific evidence over time. I think this area is really understudied and really complex. I really appreciate what Derek was saying about not only trust, but also mistrust. And here we're seeing, the levels of trust with Witness, trust with the lay health advisors, but then the mistrust of providers, medical organizations, the guidelines, and the data that informs the guidelines. So it's so multi-level, and again, so intricately tied with both historical and lived experiences of social inequality and discrimination. So I think that's critical to better understand. I think also these findings really help us contextualize this understanding of why screening guidelines might not actually be embraced by Black women in this community. Again, we often think if we just share this information, if they have awareness and knowledge, that's enough. And as we see, they do have the knowledge and awareness of this. Again, is that inconsistency between the guidelines and the data and their lived experiences and their realities. And there's such a disconnect there. And finally, I think it's really important that as researchers, we really reflect on what actually counts as evidence-based when we're deciding what to implement or de-implement or adapt. Who is at the table and actually deciding that? Who gets to decide? And really weigh some of the harms and benefits of that from an equity perspective. I often hear from community partners about how disempowering it can be when we kind of walk in with our evidence-based program that we're ready to implement or deliver, but they actually weren't involved in the development or the selection or the adaptation. And the data that where it's been tested for efficacy doesn't necessarily reflect them. So we have to be much more intentional about engaging and involving and reflecting the community much earlier than we have been, especially in the context of implementation science. And as I just wrap up, I just want to note, I think this has really important implications for how we think about our conceptual frameworks in implementation science. We've had so much focus on context in implementation science, but we're always talking about organizational context. We really have not done a good job at capturing social context or health equity or considering issues of mistrust, discrimination, a lot of these structural barriers. And as you know, if it's not in our frameworks, we won't actually get to study it. We won't, it'll show up as missing. It's so critical that we think about really explicit integration of trust and mistrust and these equity measures in our frameworks and measures. And as Haley said, I think health inequities are not new. Medical mistrust is not new. And I think with the COVID racial inequities and all the injustices that have really risen this year, I think this is really amplified. Again, a lot of these structural determinants like racism, like social determinants of health. And I think it's a real opportunity for us to reflect in our research about how we can be more explicit, again, about bringing this health equity lens. And I think we can kind of chip away at a lot of these disparities, but really addressing them will require, much more fundamental attention to these structural factors. So I just want to thank my community partners, Dee Johnson, Deb Irwin, all the Witness Project sites that participated, my ACS grant, as well as funding from Columbia University. And of course, the original founders of the program from Witness as well. So thank you.
And thank you very much, Dr. Shelton. Ellie, would you like to kind of help moderate this Q&A, or would you like me to do that?
I'd like you to help, but I see a couple questions. I'll take the first two that I see, and then you can chime in because I'm not sure I'm seeing all the feedback. But one question for Dr. Thompson is, how do you expect, where is that question? How do you expect the shift in healthcare due to, how do you expect the shift in healthcare to telemedicine in response to COVID-19 will influence health disparities, mistrust, and health outcomes of minority patients?
That's a broad question. I can maybe speak to at least a part of it. In that I know from, we work with a wide range of community stakeholder groups where I am here in Detroit and in Michigan. And we've actually been hearing a lot about the challenges of telemedicine and people's difficulties in navigating telemedicine and virtual visits. So, if I had to hypothesize, I would imagine that for a certain segment of the population, this transition to telemedicine could exacerbate some of the disparities that we see, and also cause some issues in terms of patient-provider relationships and trust. But I welcome other people's thoughts and feedback as well.
Any thoughts, Dr. Griffith or Shelton?
Yeah, I would agree with Dr. Thompson. I mean, I guess for me, it would go back to, a lot of the same metrics of success, satisfaction, and quality. And while, being able to gain access to care through telemedicine and these variety of virtual formats may solve one particular problem, it still doesn't help to overcome the quality of care issues that are faced by not having good patient-provider communication, not being able to ask the right questions, not being able to tap into things that the patients are experiencing and are concerned about, that may really, that those kinds of qualities that are more, that I think even Dr. Shelton was sort of describing in the qualitative experiences, really are not going to get captured or addressed in some of that telemedicine work. So I think it's more likely that it's not necessarily going to have that much of an effect, or if it does, it's equally likely it'll be negative as it is to be positive in addressing trust and mistrust.
I agree. And I'll just say, I mean, it intersects too with other social dimensions, right? Like age. So we're learning a lot from the Witness Project here about the challenges that they're facing, and even just continuing the program because it's such a fundamental challenge for so many of them. So I think it's complicated because there's many, I think, isms that come into play here. We think about rural, we can think about, geography, we can think about age, we can think about race and ethnicity. And I agree that it adds differently of complication in terms of that connection with your provider and just a whole other element to navigate. So I imagine that this will have some implications in terms of exacerbating inequities for many groups.
Mm-hmm. And another question we got is, how do we as researchers and community members help address these issues?
I can start. I mean, I think some of it is just being more transparent and clear about what are the boundaries of what we can do and what we can't, and trying to give people the ability and the resources and the information to make informed decisions, or to help understand how we're making decisions, or what information that we're giving to them from the sources that we're getting it. So I think the more that we can be transparent about, here's what we know and here's what we don't, rather than continuing to, like, in one of the things with COVID, for example, that people have talked about that's really undermining trust in various aspects of the pandemic, is the fact that the guidelines keep changing. And every other week there's some new symptom. Every other week there's some new guideline about what the masks do or don't do or who needs to wear them. And, the policies are inconsistent and so forth. So I think, and it's undermined sort of the credibility of the sources of information. So I think all of those factors have to be taken into account.
I agree. And I'll just say, often we try and recreate the wheel, but, there are already trusted community organizations. There already are trusted community messengers. It's more that they need the resources and the platform to do this, as opposed to us trying to come in and step in and do this. So I also think we absolutely need to work with community partners around this and provide the resources to do this. I think that will have huge implications. And I agree with Derek's point about the transparency. I think we often put the onus on the public, but we also have to demand the transparency of the institutions, right? Whether it's the pharmaceutical companies or the insurance companies that will be covering or not. This has such important implications. So I think it has to be multi-level in terms of that transparency.
Okay. Then another question we got, this directed to Dr. Thompson. Someone's interested in your decision to use ethnic group instead of racial group in the measures item.
Yeah, I saw that question. So I will say again, that was like 16 years ago, and I'm not sure, I could not tell you exactly why, the rationale we had at the time. I will say though that, as people ask me about the measure or ask me questions about administering it, I really suggest that, if you are working to be as specific as possible. So for instance, American men, replace racial group or my ethnic group with African American men, if that's possible in the context of your study. I mean, I think one of the things that honestly I didn't foresee when we developed the scale was that, how flexible, I just didn't anticipate how flexible it could be and that you could change the reference group. So that's what I would encourage. So I don't think that if you choose to use it, that you should feel that you have to use ethnic group or racial group. You can replace that with the group that you're talking about. And that's what people do. That's what I've started to do in my own work as well.
Okay. And Joe, while you're looking to see if there are any other questions, I'd like the presenters to, I know you all may have had questions that bubbled up from the others' presentations.
Yeah, well, I don't have a question. I really just wanted to hear Dr. Thompson talk a bit. I was really struck by your point about voice that you ended with. And so I really thought that was an important and powerful point. And it spoke to even what Dr. Shelton was talking about in terms of the different examples of African American women, and they're using their voice to say how they're adapting, how they're modifying, how they're making decisions to choose to trust the Witness Project versus even some of the things that we, as professionals and sitting in our little ivory tower world, would probably value more. So I think I just wanted to hear kind of both of you kind of speak to that concept of voice that you identified that I thought was so important and powerful.
Yeah, I would respond just by, I think, Rachel said it just very well, that kind of knowledge and expertise already resides in our communities. When I think about COVID specifically, there's, especially, even here in Detroit, we don't necessarily need lots of new interventions. We have a whole coalition of like about, 25 community-based organizations that came together quickly, and they're very agile. And they started creating virtual town hall meetings, in order to reach people through Facebook Live and through other sources. They already got together, and and people, they get thousands of viewers every week because these are organizations that are on the front lines, and they're already and they're the groups that people trust. They know them and they trust them. So I think as I kind of move into a different phase of my career, that is kind of what I just really see as a missing piece in a lot of the work that I've done and a lot of work that maybe we collectively have done, is just we need to give greater voice to communities. There are answers there, there are strategies there, there's resilience there, and we need to kind of support what they're doing a little bit more versus try to always ask for their letters of support and whatever to support what we're doing.
I agree. And I'll say, I mean, Derek and I, we worked on this issue in health education and behavior on using qualitative research to promote health equity. And I actually think I'm a strong believer that qualitative research is critical equity work because it does give voice to stakeholders and really does center their experience from the beginning. I think our issue in implementation science and so much intervention work is we kind of pick and choose when we're going to include the voice, right? For when it's convenient or how we fit it in, we often think about it as our formative work. And I think we have to think about it as our foundational work. We can't be doing this on, as a pick and choose when to bring you at the table and not. I think it has to be foundational. And I have loved how a lot of the COVID grants have made that really explicit in terms of community engagement and involvement from the beginning, not in a token way, but in a fundamental way where they are actually given the resources and a voice at the table. I think that is really critical because we can give the voice, but if there's not the resources behind that to do something with it, it's not as powerful. So I am hopeful about some of the funding changes too that we're seeing in this area that can facilitate some of that work.
Yeah, I think if I could even just jump in and answer my own question, I think one of the things that struck me in just reading some other folks' work, I'm actually reflecting on something that I was reading of Lisa Boleg's work in HIV prevention, where she was talking about the importance of capturing unintended benefits or the unintended, not necessarily consequences, but implications of interventions that qualitative research allows for being able to do that. Sometimes there are benefits, sometimes there are things that we are able to capture through those tools that we can't capture through some of the more structured tools that don't give you the freedom to hear from people what actually mattered to them, what actually was important to them.
Okay. I have a question I'll pose. One thing I've always struggled with is whether this idea of whether trust is mutable or changeable. Do interventions actually address it? Or will it really require more fundamental change related to structural determinants and social inequalities in health to change it? And I've thought about that a lot in the context of witness, I'll say, because I've actually measured trust at multiple time points over the past 10 years, and it honestly hasn't changed that much in terms of their own personal experience of discrimination, their own medical mistrust. I have seen a slight shift in trust of the guidelines, but it's really struck me that even though they are these messengers of trust in the community, it doesn't necessarily mean that their own medical mistrust is being shifted by this. So I'm just curious what you all think about with respect to this. Is that our goal? Is this possible?
Yeah, that's my first response is that even should that even be our goal?
Yeah.
Change or reduce medical mistrust. I often think about it as something that's protective, right? In a lot of circumstances or settings, and maybe one goal of the interventions is really, what do we do? How can we supplement services or the information people receive to kind of to maybe move past that medical mistrust, not to reduce it, but to at least mitigate it in some way.
Yeah, I think for me, it kind of goes back to why I was sort of making a big deal about some of the semantics of distrust versus mistrust and so forth, because while I think what you're seeing in the consistency and the persistence is really about mistrust, this overall thing that you need to potentially approach research, approach care with a level of skepticism, just because it's very likely possible and historically grounded that there's potentially something amiss that you may not get the best quality care from that particular provider. But I think you can do things when it relates to distrust when it's specific to particular providers, organizations, institutions. So I think if you were to measure, for example, the trust that the women who are connected to Witness have in Witness, that may be changing, that may grow. And within, like if you were to measure the trust in the lay health advisors, that those kinds of things may grow and so forth, while the mistrust that is just the phenomena of, do you have some skepticism that you approach all of your experiences with health and health related issues with, does that seem to be consistent? So I think that's where that semantic difference becomes really important. And I do think that we can change some things as it relates to distrust in specific organizations, institutions, and providers. But I think the mistrust is not something we're likely to probably, or it requires change at a higher level, like you were describing, that really does require that structural change.
Yeah. One of the questions that I saw in the chat had to do with what do we, beyond, what do we do beyond training providers around implicit bias and, cultural sensitivity training? And, we can just take it up to another level. What is that, providers work within the context of organizations and hospitals, right? What is that hospital's policies or practices that may be feeding mistrust? Or what could they be doing differently to increase trust in the services they provide? Is that hospital working with community-based organizations that are known in the community? What kind of partnerships do they have, and how are they conveying, those partnerships to the broader community in ways that could maybe bolster trust and maybe buffer the effects of mistrust?
Yeah. Just to build on that, what are they communicating about the limits of what they know and what they can do? And are they presenting it as though I'm basically going to ride in on my white horse and basically solve all your problems by providing this care? Or am I saying, look, I can only do this much. I can do this much very well, and I understand this part of it. We don't really understand this other part, and that may also affect what you're doing or what you may experience. But we have to kind of find some balance between being, providing basically the answer and solving other problems and kind of, presenting ourselves as though we have the full answer and all of the information, versus being more honest, humble, and modest and saying, maybe we don't have all the answers. But part of the reason that people lack trust is because they find that, there's something that they weren't told, or some misinformation that they got, or it wasn't the complete full story. And if we don't trust that people can potentially understand that information and deal with that nuance, then they're not going to trust us, because we're showing that we don't trust them either.
Yeah. Okay, so if anyone wants to come offline and ask a question or respond to Joe's question about what can ACS and other funders do to advance health equity, now's the time.
So I don't know, one of the things that strikes me, and it's, it's somewhat of, it's a different issue across different funders. I think maybe it's more striking across NIH, but I'm always just, it's just interesting how there are people who can have lengthy careers working in racial or, other types of social disparities in health, very successful careers, and never really engage with community members, right? PCORI demands that you have a whole, community engagement section, and they have rubrics for compensation and all that. And you have to really show not only that community members are involved in your work, but they actually had a role in developing the research proposal, right? And I would like to see more of that across all funders.
Okay. Dr. Hirschman, our clinical research professor, do you want to ask a question? You're on mute, Don. Dawn, you're on mute. Okay. No.
Well, anyway, it's good to see you, Dr. Hirschman.
Yes.
Hello.
So if I could just answer your question, the question that you asked, Dr. Daniels, I think I'm struck in the context. Your question also strikes me back to sort of what Dr. Shelton was presenting, and that ACS seems to be one of the more trusted institutions, even when you compare them to others that are in the field. So part of I guess one of the things I think ACS can do is continue to, there's something that you're doing that actually is working, I guess is what I'm saying. And so I guess for, funding part aside, I would think that doing what you're continuing to do in terms of advocacy, in terms of connecting with the community, in terms of educating people in the community, in terms of how you're being transparent and really independently evaluating the literature, evaluating the guidelines and so forth, that continuing to do that is gaining you a lot of credibility, even when you compare yourselves to other sort of blue ribbon panels of experts in the field and other institutions that we tend to look to for guidance. So there's something that you're doing well that I would just say keep doing.
I hope Dr. Kantz is still on the line and Dr. Phelps to hear that. Thank you.
To that, I'll say what I appreciated about the application, and I don't know if all applications are this way, but there was an explicit section that really had us call out what the implications were for health equity for the Research Scholar Grant, and it make that really explicit. And I don't think that is explicit in a lot of applications at NIH. So I appreciated that, and I also appreciated that there was an explicit plan for dissemination, and it wasn't that one paragraph. You know, it was a page about like how will you communicate this with your stakeholders and your community partners. So I think those kinds of nudges can be really helpful in helping people reframe some of the work that they do and making it really explicit. So I think those are helpful.
Okay, so Dr. Hirschman wants to know, how can we use what you learned to improve clinical trial? Messages keep coming up, so I'm not getting all of her question, but to impact clinical trial enrollment.
Now, one of the studies I referred to kind of speaks to that somewhat, and maybe part of it is kind of addressing the elephant in the room, right? Because it's one thing that you may like your oncologist or like your physician and feel good physician, and they make this clinical trial offer, but you know there's something unspoken, right? The folks who had, at least in that one study, the folks who had higher race-based medical mistrust were less willing to discuss those trials. And we need to have more open conversations about what this means in terms of African American healthcare and that legacy of research abuse. You know, so that's one thing, you know, that I don't think you know, that our physicians and our researchers really do.
I think just to add to that, one of the things I'm struck by is I would kind of flip it. I think Dr. Thompson kind of alluded to this a bit, that so one of the things I know that tends to influence whether or not people are actually willing to engage in clinical or participate in clinical trials is whether or not they're asked. Yeah. I mean, and I think we don't assume, we look at certain patients with certain characteristics and make assumptions about whether or not they're actually going to be willing to do it, whether or not they're going to follow through with it, whether or not they're just going to take the incentives and run and screw up stuff because they don't want to answer the questions or whatever. I think we have to, as the researchers, providers, and so forth, have to have more faith in the potential participants to actually give them the information and to trust that they're going to be able to, you know, act in good faith to do this kind of thing that's going to make our science better. So I think that's a really important point.
I agree. And there is some research actually suggesting that when African Americans are equitably approached and educated in a transparent way, the rates of clinical trial participation are very comparable. So again, I think that's a really critical point.
Yeah, and that was research that what I was referring to was research that a colleague, Aisha Langford, did as part of her dissertation at Michigan. She's now at NYU School of Medicine or Population Health, something in that space, and under the work of Dr. Ken Resnickow at the University of Michigan Cancer Center and School of Public Health. So I think that's one of the things they found is that that's really important from that perspective.
Okay, so we're about at the end of our time. Is that correct, Joe?
Yes, ma'am.
Yeah. So I really like to thank all the presenters and everyone that joined today on Veterans Day. We appreciate all the veterans for their sacrifices in the efforts to keep us safe. I hope you have a nice holiday season. And our data science group has invited a clinical research professor presentation on racism, Dr. Nancy Krieger. So look forward to an invitation to that presentation. Joe will be sending that out. All right, thank you.
Thank you.
Thank you again, everybody.
Take care all. Thanks again.
Take care.
Bye-bye.